I'm Jessica Wilson, and you're listening to Making It Awkward. Welcome back. Today's episode is the feedback episode about my conversation with gender-affirming surgeon Dr. Blair Peters. He told me about the technical and personal limitations to doing surgery on people with higher BMIs. This episode features emailed questions from Laurel, some shared reflections from B, and a video from Dr. Asher Larmie that is both deeply personal and provides feedback as a fellow medical doctor. I talked through all of this, including my own thoughts, with Zoe and Isaac, two non-binary colleagues. Before we get to those thoughts, I want to thank Benny Dexter for the review and saying that the show is awkward in the best way, which, let me tell you, one of the best compliments. I also want to share an update on the last feedback episode I recorded. If you recall, Whitney Trotter and Megan Seichi joined me to talk about IADEP and Stephen Dunn. This week, Steve posted a 1,100 plus word blog entry about the feedback episode, including the text of his email exchanges with me and Whitney. To be honest, after the second paragraph ended with, I thought there was a feeling of respect, of professionalism, of courtesy. I certainly extended those qualities to the two hosts. However, it would appear that those feelings of respect and professionalism on the part of the esteemed hosts may have ended that day, if they existed at all, end quote. After that, I skimmed most of it and skipped right on over to see what he'd quoted from my emails, because I can be a bit spicy at times. He'd pulled out my response to his suggestion that Whitney and I volunteered for IADEP to fix its certification process and make it more inclusive. I'd replied, quote, I cannot take on the full task of improving the certification, but I'm happy to provide paid consultation to those who are interested in my experience. To which Steve summarized as, I can't be bothered unless you pay me. And to that, I will say, phew! I'm so glad it came across as I intended. I'm glad I didn't leave any room for someone to assume that I would provide unpaid labor for them. It's such a relief. I also want to express my gratitude to Steve for promoting my podcast and sharing it with his followers. I can tell it's working. His episode has the most listens of any other on the platform, and I'm sure with his help and with the IADEP conference coming up later this month, I'm sure the numbers will only continue to grow. I also think that this is an example of this podcast setting out what I intended it to do. I wanted to change the narrative about eating disorders, about bodies, about Blackness. And this podcast, getting into Steve's arena, into the conference arena and the organizations, I think is just one example of progress. Now, on to today's feedback episode. A note for listeners, this episode includes discussion of suicide and anti-fatness in medicine. Welcome to the show. Go ahead and introduce yourselves.
My name is Amaro Jimenez. I'm a clinical psychologist. I work for a community mental health center with some pretty rad people, non-binary. And I think relevant to this conversation, I'm someone who has undergone gender-affirming surgery and is thinking about going through more.
Hi, my name is Isaac. I use they, them pronouns. I work as a patient care coordinator at a community clinic that focuses on trans care. I'm also trans and non-binary, and I guess as well, I've also had gender-affirming surgery. Thank you for having me on.
Let's do our first impressions of the episode with Blair.
I was actually nervous listening to it because I was nervous about hearing something I didn't like, and I think that positively colored my listening experience. I think something that stood out to me was Blair's kindness and care and consideration that they put into their work. I did appreciate the discussion. They didn't do the sometimes annoying, sometimes helpful thing of naming this is a systemic oppression, but they talked about the levels of the system that is impacting care. I'm someone who, as a clinical psychologist, did not get medical training, so I appreciated the details around where things get difficult to access for fat folks. So talking about the details of the different kinds of surgeries, where things would come into play. And I did appreciate Blair talking about how a lot of this is about training, because there are parallels there with the work that I do. It is important to name if I don't have the training, if I'm like at my limit, like should I be working with folks? Like, am I putting more people in danger by stretching myself too far without the training that I need? I had more questions and just like other pieces that I would have loved to hear more from Blair.
You are so much nicer than I am.
Well, we're talking about first impressions.
Yeah. My first impression, I also will agree they were very kind. And I could tell that they like cared about the work that they did, which I can't say for all surgeons. So, I commend that. But I do feel like there was some sort of like this delivery, there was times where it was very much like, woe is me, even though you are a surgeon who probably makes more money than these patients. And there was a specific line that got me, which was like, yes, there is a power imbalance, but at the end of the day, there's a person across the room for you. And they're talking about the surgeon, but the same thing can be said for the patient, and it took them a lot to get to that point. So there was just some of those things where I tend to get really critical, when there's people in power, when they speak about things, when people are, marginalized and have less power. So I was just very critical of the way it was delivered. Another thing that kind of like stood out to me was that they never said fat. They just said larger bodied. And that kind of informs me that they haven't really been around a lot of fat people, or maybe not fat activism space, because they're trying to reclaim, fat, and it's not bad to be fat. So I don't know if there's a disconnect there, but that's something else that kind of like jumped out at me. But yeah, I really appreciated the technical aspect as well, because I'm not that well versed in that. And that actually, listening to that episode is not going to help me when I have to have conversations with patients who have, higher BMI and are interested in these procedures, just like some more knowledge that I just didn't have from the training that I got. But yeah, just want to say, I guess I follow like Dr. Peters on Instagram, social media before I saw this. So like I kind of had a vague understanding of them. And I was just a little disappointed in how they spoke about some things in particular. And then I just think they could be a little bit more sensitive when it comes to certain things. Like, it feels like I've been hit by a bus. Like, I get that it's challenging on your body, but like that people are always like kind of told that they have like the burden. So I'm like, just be a lot more sensitive, I would say. Yeah, let me just put myself out there.
That was great. In addition to the things that you all have mentioned, it was clearly thin-centric in a way that I'm still struggling to fully like articulate. From a very like technical or monetary standpoint, when it comes to the cost of surgery, when it comes to the time, when it comes to all of these things, like I don't know why we just don't like allow like reimbursement for differences, assuming that bodies are going to be different. So that was like a very specific part that I'm still struggling to like fully discuss. I think about dogs. I think about Great Danes. I think about teeny tiny dogs. I know somebody in vet school who has not complained about having to work on a Great Dane or a Chihuahua. Like there's just this way that we inherently have anti-fat bias, but also are just enacting the same things that we're saying that we're not doing over and over again, it seems, without even recognizing it. So of course we can't separate that. I think the thin centrism, the anti-fatness showed up as well with the just not the expectation that things are going to take different times. Like clearly this is all about thinness. We've decided that a surgery should take a certain amount of time. And if it does, when it doesn't, it's over that time. Like it's more time. It's not just like we allowed a surgery and it takes however long it's going to take. It is like fat people just take longer, which implies that there's like a window that it is supposed to take. So just these norms that have been just built in, I was noticing a lot. And in the moment, I wasn't able to like really question, but that have come up for me. And the part where I was able to say it in the moment, like there's the barriers of housing or not having like clean places to clean a wound, that seem very specific. And because of the way that our society is structured, there's just a lot more compassion, I think, and the conversations are just different. But when it comes to people's bodies, granted, because of society, it's loaded differently. But just in the way that we were talking about it, I couldn't put my finger on what was feeling very not okay. And I'm not sure if I'm able to do that right now the humanization, the dehumanization of it all was definitely there. And I was fully participating in it, talking about adipose tissue when, these are humans. Like, I was fully participating in it. I didn't like it. I appreciated the technical stuff. That was so valuable. Like, I fully understand how things are different. And yeah, it doesn't sit well with me for some reason.
The part of me that like first listened to it and was really impressed was like, wow, the degree to which Blair humanized patients was notable to me, which speaks a lot to how low the standards are.
Mm-hmm.
And I think everything you said is correct. Like, there is still ways that we as clinicians talk about people as parts, as symptoms. Like, obesity is labeled a disease, and I see it everywhere, like working in a medical establishment, like just being in the world. And so when we're talking about gender affirming care and fat people, we're talking about people who are marginalized, who are consistently being asked to sacrifice their health by engaging in a system that is supposed to like help their health, to keep them healthy. And we know that that's not true.
I guess another thing, I've listened to the podcast like 3 times. One of the most pivotal things that stuck with me was, I guess, like the focus on, or it was mentioned a few times, like cancel culture.
Yeah.
And cancel culture, and saying that there's really extreme radical activists, but then also saying that patients need to be radically honest with their provider.
Mm-hmm.
So I feel like there was just like, what is it that you want?
Mm-hmm.
And also, like, at the end of the day, if somebody like leaves you a bad review, you're still going to have your practice. You're still going to be okay. You're going to be fine. At the end of the day, the person's going to leave that consult not being able to have surgery, and they're going to have a lot more to lose than the surgeon, So like, it feels like very much when like celebrities are like, oh no, you're trying to ruin my career, but it's like, you're still getting acting roles, So like the focus on cancel culture just seemed to like take away from the person who's being marginalized and redirecting the attention to the person who holds power in that situation. And that's another thing that just kind of rubbed me the wrong way. And I feel like a negative Nancy, but that kind of is my vibe. So I'm going to keep it punching. Also, transparency. I work with a lot of surgeons, and I have a lot of anger for certain things that I've had to deal with surgeons' offices. So I probably come with some sort of trauma with surgeons. So that might also be framing my reaction.
I don't think you should be apologizing. I think that's real.
Well, thank you. Yeah. So yeah, that was a big thing for me, because I'm like, it should have been like more reflected on how can I help these activists, do something, as opposed to like, oh, this activist is trying to cancel me. Like, the end goal isn't to ruin your career. The end goal is to have fat people have surgery, So that was just some other stuff that I was thinking that made me a bit disappointed, because as I said, I had been following them. So I'm like, hopefully it was just like worded weirdly. I don't know. I don't want to give excuses, but that's how I felt.
One thing that I like really wanted, well, there was like several things that I really wanted to know. One is that like thinking about how Blair Peters is like above the standard, but the standard is too low, is that just becoming any kind of provider, there's like this implicit, very intense message of like, you're here to help people and you're doing good. You're really out there doing God's work, which like totally reinforces a like savior complex. And I think like that white saviorism like gets in so much of our way as providers to like receiving constructive feedback from people who are making good points. At the same time that I'm saying that, there's a part of me that's like, I don't want Blair to think that I'm attacking them. Like I'm feeling the like nervousness, which is fascinating to me. And speaks to the way that like there is a power differential. There are real impacts to talking back to people who have more power than you, that have your health in their hands. And like, I think Blair, like a lot of people may know what this is like. Like, I don't know their personal history or their medical history. And I think being able to hear people's feedback about what that is like feels like a good place for like surgeons to go to like improve what it's like, because it is a deeply nerve-wracking, overwhelming experience. Even when you're like an easy, quote unquote, easy case, It's still, you're still a person having an emotional response. I think about that a lot as a clinician, as a therapist, and like intakes. It can be a really nerve-wracking experience, and I try to remember that every time. I'm not always good at remembering it, but I try to.
I think that teed up our first bit of feedback really well.
Hi, it's Dr. Larmie here. I am a trans mask doctor, GP. I've been a doctor for roughly 20 years, and I am fat and currently being denied gender affirming surgery because of my BMI. I'm very grateful for the conversation that you had together, Blair and Jessica. I thought it was fantastic. I found it really helpful. I have some comments about some feedback that I'd like to share with you, and I thank you for this opportunity. I've written them down. I got notes in case I forget. So first things first, I want to make a point that kindness does not necessarily translate into being weight inclusive. You could be a really kind, caring, compassionate doctor that cares very much about fat people and cares about discrimination against fat people and believes it's wrong, but still not be weight inclusive. You can still be harming your patients. You can still hold a lot of anti-fat bias, implicit anti-fat bias that you're not aware of. We all have implicit anti-fat bias, all of us. And that's because of the way we've been conditioned. And I think it's really important to recognize that kindness isn't necessarily, a marker of how safe fat people are around us as doctors. And there are many times when a patient has walked out of my consultation room and I've been like, yes, that was a really good consultation. But actually, they would say something completely different. Unless we're actually listening to their lived experiences, unless we're listening to their feedback, how could we possibly know? Just because they seem happy doesn't mean they are happy. And I think we as doctors are terrible at centering people's lived experience, at listening to what our patients have to say. And this is particularly the case in patients who do hold marginalized identities and are experiencing discrimination and are struggling to access good quality healthcare. I wanted to make the point that we as doctors tend to have a lot of privilege. And, as a transgender doctor, I don't actually know that many other transgender doctors, but in general, we tend to have a lot of privilege. And even though I am trans, I also hold a lot of privilege, like white privilege, to begin with. And I think that is very problematic. If we do not acknowledge the amount of privilege that we have, we fail our patients, especially those who hold one or more marginalized identities. We have to start centering the voices of Black and brown and Indigenous and fat and queer and trans and disabled, neurodivergent people. We have to start listening to how we as doctors are delivering care to them, because it's not as good as we think it is. And just because we care about these groups of people, as I said, doesn't make us safe around them. And I think there's a real risk of doctors taking on the role of the white savior, performing the role of the white savior. That white saviorism, like it reeks. Sometimes I'm in a great room full of doctors and I'm like, ew, this is gross. Because, we want to be kind and do the right thing and help our patients and all of that stuff. But, it can turn into, I want to rescue my patients and I'm going to be the one to center myself in the situation. And it's tricky, right? It's a complex and a nuanced conversation, but I think it's really important to talk about white privilege and white saviorism and white supremacy whenever we're having conversations like this. We should be centering these important issues in these conversations. So that's the first thing I want to say. Maybe it was two things. I found it really interesting, the conversation about incentivization, and it's something I could definitely relate to, but I think it's something that has become very problematic in the field of medicine. I understand why almost every doctor out there would be like, well, every surgeon, why am I going to do a procedure that's going to take me 3 times as long? It's going to be 3 times as difficult. And when I'm being paid the exact same amount to do a simple one. And that doesn't matter whether you're a private doctor and you're literally charging patients, or if you're salaried like me, I'm a salaried doctor. I know, okay, I'm not a surgeon, I'm a GP, but I know that some of my patients are going to require more of me than others. In the UK, GPs get 10 minutes with each of their patients. That's the reality. And I'll be honest, I'm quite a good doctor, and I can do some consultations in under 10 minutes now. Like if you've got something simple like a sore throat and you've got tonsillitis, not a problem. I can get that done under 10 minutes. Many of my patients are going to require more than 10 minutes. Some of them are going to require 20, sometimes half an hour, sometimes even an hour. Some of them are going to be easy, and some of them are going to be very demanding and challenging. I get paid to see this many patients. But of course, it's very tempting to call the less complicated ones, the one that require less time, to call them the easy ones and the others the difficult ones. To say, this is simple, this one's complex, this is, and let's face it, we have favorites. This is better for me. Spending 7 minutes with a patient and getting a 3-minute break is way easier for me than spending 20 minutes with a patient and running late. But what happens is we end up blaming our patients. We end up treating our patients differently depending on how much they require of us. And that's not okay. It's just not okay. I've come to the realization that some of my patients are going to take 7 minutes and some are going to take half an hour, and everything's going to work out in the wash. And I don't want to discriminate against my patients. I don't want to harm those who are more complex, because it's not their fault. It's nobody's fault. It just is. It's the situation. So yeah, capitalism, white supremacy has really impacted how we as doctors view our patients. And yeah, it's a hard job, by the way, being a doctor. It's not easy. But it is the job we chose, and if we can't hack it, we've got to find something else, right? I mean, it seems reasonable. We shouldn't punish or penalize patients for being more complicated, is what I'm trying to say. I found the conversation about limitations really useful to have it explained in detail, because I'm not fortunate enough to have met a gender-affirming surgeon yet. So I want to speak from personal experience here. I have already made peace with the fact that I'm not going to end up having bottom surgery. A phalloplasty is, as much as I love one, it's not going to happen for me. I made that decision before I listened to this podcast, but I'm much more sure of it now. And that's because I looked into the surgery and I was just like, I don't think my body can do that. I don't know that I'll recover from that. Even just the skin grafting from the arm, I was like, I'm not sure even my arm can handle that. I'm not sure I want to go through like the laser hair removal and all of that stuff. Like, I'd made that decision for myself. But it made me think, though, when the conversation sort of went on to sort of chest surgery, I was like, I don't have particularly big breasts. They're quite small. They're basically a small handful. I haven't got friends who are much smaller than me but have larger breasts. And it made me think, like, we're generalizing people who have a body mass index of over 35, over 40, whatever it is, your limitation. Oh, well, they're all going to have large breasts and they're going to be more complicated. But says who? I got small ones compared to others. So there's that kind of generalization that I didn't particularly like. I'm not suggesting that that's what Dr. Peters does. I'm just saying that it's the generalization that surgeons often sort of like, we're all the same. All fat people are the same. Our bodies all look the same. They don't actually look the same at all. All bodies are different. And I imagine that there are some slim ones, the ones who are under a body mass index of 35, who actually have a heck of a large amount of breast tissue. Also, I'd like to point out that breast tissue massively adds to BMI. So there's that too. I guess what I'm saying is, like, I have come to terms with not being able to have phalloplasty, and that's really hard. And it's something I've had to grieve. But at the same time, I don't know that everybody who is the same body mass index as me is going to feel the same. And I don't think that we should necessarily just be like, nah, it's not possible. It's got to be like, a case-by-case basis, in my opinion. I think the final point I want to make is, who are these activists who are so black and white and just unwilling to accept that sometimes gender-affirming surgery is not possible because of BMI? I'd really genuinely like their names. I'd like to meet them. I'd like to have conversations with them, because I'd like to think I know a lot of them. I'd like to think I know a lot of people in the kind of weight stigma activism space, and I don't know any who would be that unreasonable. As a doctor, there are times when I just have to say, look, I'm sorry, I can't. Like, I get that you want to try this medication, but it's contraindicated in people with your medical history or family history, so I can't. I get that you want to do this, but I don't have access. Like, you want an MRI of your knee. You need an MRI of your knee, but I'm not allowed to request one at the moment because I live in the NHS, I work in the NHS. There are times when I just have to be blunt and say, I agree that it would be ideal, but I can't do it, and here's why. I'd like to meet the activists who would argue that I'm not doing my job properly because of that. Like, let's have a conversation. I'd like to think we're more reasonable than that. And we as activists get accused of extremism all the time, unfairly. Part of it is because, yes, Instagram, as Dr. Peter said, Instagram is not a great place to do activism because you get 90 seconds or whatever, and like, it's just not enough time to have these conversations. But it's so frustrating that those of us who speak up and fight for the rights of those of fat people, rather like fighting for any marginalized group, we get accused of extremism the moment we kind of open our mouths. You know, you've got to constantly police what you're saying, and I find that I found that a bit triggering, to be honest. I hate that word triggering, but I'm going to use it anyway. I found that quite triggering when I was listening to that part of the podcast. The last thing I want to say, did I say the other one was the last thing? But this is definitely the last thing I want to say. You have to remember, and Dr. Peters has to remember, that the vast majority of people, of trans people, never get to sit in front of a gender affirming surgeon and talk about bottom surgery. We never get that far. We are denied access long before then. If you live in the UK right now, where gender affirming care is absolutely legal, the average waiting time is between 3 and 4 years just for your first appointment at the clinic. The only correspondence I've had from the Gender Identity Clinic has been a letter addressed to my dead name, by the way, saying you're on the list. That's it. I've been waiting a long time, and people have been waiting much, much longer. That's the first thing. If you live in the States or in other countries, there will be some areas where it's not legal to access that care, or the care simply doesn't exist. And even in other states, it requires money. It requires a lot of privilege just to get to sit in front of a surgeon. Most of us don't get there. And like, it hurts me to say this, but we feel so excluded from the conversation because we don't have a voice. No one's even listening to us. They haven't spoken to us yet. They haven't even seen us. We can't afford the surgery. So we don't have the insurance or whatever it is that it requires, or we're just being told you can't have it because there's a BMI limitation. It's so hard and surgery, like, that's the end stage, right? Like, do you know what we've had to go through to get to that point when we're sitting in front of a surgeon? So doctors have to remember, especially surgeons have to remember, they see the end result. By the time a person is sitting in front of a surgeon, they have been through, I don't know how many countless consultations and procedures, and like even coming out, like before they got there. We need to be part of this conversation, not just the people who are fortunate enough to have gone through the surgery and have their photos taken for a website. They are the lucky few. The rest of us have to grieve the fact that we'll never, ever get to enjoy that experience. I will never be able to look at my body and say, yeah, that looks like I want it to look. I will always struggle with gender dysphoria. I will always have to find a way to keep my suicidal thoughts and my depressed thoughts and all of that. I have to find a way to deal with them because I don't get the privilege of gender affirming surgery. It will never happen for me. So I'd like people to remember that, please. And thank you once again for giving me the opportunity to give my feedback.
Thanks so much to Asher for sharing that with us. It is incredibly powerful. I know that all three of us have shared how impactful that was on our understanding. Isaac, I'm going to invite you to share a bit now about what you do. Something that I think is important about your job is that you hear all the in-between parts. So Asher was talking about how, surgery is that end stage, is like their end result, like what they have been doing all of this work for. And you are super present for, all of it, especially that middle part. And if things don't go well, like, you're the one that hears about it.
Yeah. So my role is essentially I help patients navigate getting surgery. My title is Gender Affirming Care Coordinator. So I kind of am the liaison between the patient's medical provider and the surgeon to ensure that they get a referral and get it covered by insurance. So I kind of am the point person to help patients get a consult, which can be super challenging, and it has a whole bunch of requirements. If people don't know, if you're pursuing gender affirmation surgery, you typically need like a letter of support from a medical provider and a mental health clinician. And if you're pursuing like bottom surgery, it's usually 2 letters from the mental health provider. And that's its own barrier in itself because you have to find somebody willing to write a letter. It can take time. There's a huge wait list and it can be expensive. So that's a barrier for folks. It's unfortunate that it can take so long, and it really varies based on people's like ability, in the sense of like if they have money, they can kind of get through the process a little bit faster. Like where I work, it's a community clinic, so we tend to have folks who are more low income or on Medi-Cal, and thankfully we have people in our clinic who can provide letters of support. But again, it can take time. There's also like resource issues of where you're going and how much staff there is. But on top of that, like there's certain things that surgeons will have or not want to accept certain patients for certain reasons. Like let's say BMI is usually one of the biggest ones, but apart from that, there can also be substance use. And they want you to have a substance use plan. You don't have to necessarily stop using because we're harm reduction, but it's more of creating a plan to like recover and have optimal recovery, as well as smoking cessation and all that stuff. But I've seen a lot of folks who are thin and have other issues with their care, as like, let's say housing or substance use stuff. They can still very much be streamlined through and get a surgery date. And I don't know what due diligence that is, but that happens sometimes when there's fat patients where their only health issue is their BMI. They will get like blocked from going anywhere. They can have the support in place. They can have a place to recover. They can have all the friends, but their weight is the thing that's stopping them. And that's always a really challenging conversation to have. Thankfully, in where I work in the Bay Area, there's a lot of surgeons who don't have BMI cutoffs for top surgery. But again, all the other surgeries, there's usually some sort of BMI limitation. I have patients who have been trying to get in front of a surgeon for like 2 years, you know, like, and there's other people who can get a consult in 3 months. So it's just really emotionally, you know, challenging to see so many people who are prepared to go through it, but just can't because of this one thing. And that can also trigger other things that they might have in their history. And
I think something that I'm thinking about as like you're talking about your job is that as a therapist, I'm like one of the people writing the letters. The thing that always strikes me is like, I, like personally speaking, with my gender affirming surgery journey, I had a bad time like all the way through. Deciding to get top surgery was really emotional. I was second guessing myself the whole way through. I had to like check in with myself a lot about like, would I be working this hard if this was not something I wanted, you know, like, but I had to like rely on my behavior. I was on Medi-Cal. I had to change count. I moved to be able to access surgery. So that added an extensive amount of time. My letter was done with a lot of care, and it still was an extremely traumatic experience. I was in school to be a therapist. Like I know what these letters are for. They are not for the patient. You know, this is not in line with someone's well-being. Like, I think knowing that made it harder for me. And it was like, I broke down during it. Again, still, I'm like one of the lucky ones that Asher was talking about. And it's still like, it can be traumatic all the way through, and something that now that I'm a provider and I've had a long break from surgeries that I might have to go back to, and I'm like looking forward to it, as you probably could imagine. I'm really struck by like how the medical system has like convinced people that I am like doing something good when I'm writing, when I'm like quote unquote assessing these people and writing letters. Like just this morning, I had someone deeply thank me for the service I was providing them. And I know that like I am like, I'm like one of the gatekeepers, and I'm saying like, yes, you can go through the gate, and that may inspire some positive feelings out of people. But the system is not good. I want to not have this job. But I have this job because I think I do it in a way that's compassionate. I think that's a piece people miss. But just because people are having a good response as they're being told something like, you have a BMI that's above my cutoff, or is like not safe to operate on. We need to figure out a solution. Like, you may be kind. I think I just want people to recognize that what system we're participating in.
Also, sometimes patients are going to be nice and react nicely to what you tell them because they have no other option. There's like, based on their insurance, there's only like 2 surgeons or something that will do that procedure. So it's not like they can like lash out on you, you know? So you might think a patient took something well, and then they went home and cried about it or thought about it for the last 2 weeks, which is something that's happened to me personally. Yeah. I went to a doctor and went about something gender affirming care. They said something, which I think they tried to deliver in a certain way. And I was insecure for like 3 weeks after. I was nice to the doctor, and and even though my job is advocating for patients and doing that, I've struggled to do that for myself because it's still scary. And I haven't confronted my doctor about this. But there's still like, you must understand that you hold people's health in your hands, and they're going to do what is possible to, you know, get their care. And they might just not be truthful to you because of how you might react. And that is something that I grapple with too when I work with patients, because I often think about being a gatekeeper, even though I have no license, but I am like the person submitting referrals and things like that. And it's really challenging to have to like hold that role and deliver the bad news that the surgeons don't want to necessarily tell the patient. And I have to then convey that and tell them, you can't go there. Yeah, I'm the messenger, and people love to be mad at the messenger, which I totally get, because I would be mad too. But that's another thing that I think Zoe was talking about, like being transparent. I try my best to be transparent with patients about like capacity, the places they go to, like being in this role for a minute and referring to the same surgeons. I have a lot of experiences, and there are certain places where don't have BMI cutoffs, but it doesn't mean that they necessarily treat the patient great. So there's a lot of things that you have to juggle. And it's just not a fun experience. And I think that I understand wanting to humanize the surgeon, but I'm like, let's also keep in mind that the patient's also a human, you know, like that is also very important.
And fat people are having these kind of interactions potentially almost every time they're at the doctor. And I'm someone who has a higher BMI and presents as a thinner person, and like, I'm getting shit. So like, think about who we're talking about, like fat trans people. Like, they're already getting shit constantly from the medical community on top of being trans.
Definitely. Asher also mentioned the white saviorism of it all. And at the US Path conference, like, not just the white saviorism, but like the cis saviorism was just so deep. It was just like a stew of this weird, like, gay man saving the trans people. You know, I really want to convey my support for the trans community. Like, I am doing the Lord's work with, you know, my gender affirming surgery practice that's probably making me so much money, but that's fine.
Yeah.
Yeah, it really, but also felt like you're making money from trans people as a cis gay man. So, yeah, the white saviorism, and then a lot of other stuff in there too. And the extremism portion of it, you two have, you know, alluded to it, and Asher definitely did. I have definitely engaged in the all or nothing, you know, all plastic surgeons or all gender affirming surgeons or fat phobic or something along those lines, I'm sure I have said. And I think that there are BMI cutoffs for the majority of practices because of anti-fatness. You know, like the reason that people don't learn these things in school is because of anti-fatness. So I hear what Blair is saying when he gets the feedback that, you know, you're just fat phobic. That's why you have BMI cutoffs. And I think that's the personalizing of it all. Like, I can say, like, I certainly have not been trained. Like, there was anti-fatness in my training program. And yes, like, that has made me unable to do surgery on everyone, and not take it, you know, personally. Just be like, that's the system, you know, and I am participating. Yeah, I'm participating in that because that's how I was trained, without like making it about oneself, you know? And I get it. It feels personal, but it's just a symptom of our anti-fat society. So that was a piece that was kind of missing there.
It's like that personalization that I think a lot of us have been taught is like such a tool of white supremacy. And again, like, not saying Blair is a white supremacist at all. It's just like one of those things where it's like, when Blair was talking about like the activism was the way that I, as a Latina who of indigenous descent, was like very explicitly taught by my indigenous mother, like, this is the way you listen to feedback that might actually be incredibly disrespectful, and like put your ego aside, hear whatever good criticism, like constructive criticism out of that potentially very disrespectful, or the compliment, or the compliment out of the incredibly disrespectful thing, so that you can keep succeeding. And I think there's a lot of people who have enough access and enough money and enough of whatever to get through all of the schooling it takes to become a doctor, to become a psychologist, to become a therapist, that don't have to learn that skill, or at least most of them. I'm safe saying most of them, that when they're getting constructive feedback, they don't have the ability to like depersonalize it, you know, to just like hear like this is a system issue. And I think, and I'm like, you know, I'm sitting from a place of like, I explicitly also got trained as a therapist to de-escalate situations, and to be able to do that skill too, and be like, this person's yelling at me right now. Can I like figure out what actually happened in to my perspective, because we're also just humans having very two separate experiences, and what they're mad about that I may or may not agree with personally, but can I validate what happened for them so that we can come to a place where we can like come together. And I think like that skill wasn't there around the activism piece of this, because like, of course people are mad.
Yeah.
Like the system is not good. I'm really refraining from cursing.
Why? This is an explicit podcast. It goes,
the system is fucked.
Yeah.
The system is fucked. We have to participate to some degree in some places always, you know, like, so just own that the system sucks. Own that people are mad at you because of like the part that you have to play in it. Yeah. Honor that shitty part, and then be like, okay, like what feedback can I take from that? You know? I'm annoyed, and I know that I don't do it perfectly. No one does it perfectly. But it just, I don't think that like labeling activists as like too radical something is like unproductive, ultimately.
I fully agree, and I'm confused by a lot of this in the state of trans care and legislation today. What are we doing if we're not doing advocacy and activism? We had a great email from Laurel, which I fully appreciated. It was like 10 follow-up questions. I want answers to all of these things. It included the language of adipose tissue. And I will say that right after I recorded that interview with Blair, that I text Isaac, like, oh my God, I can't get over how many times I use the term adipose tissue. What are we actually talking about? This is weird. Okay. Laurel brings up that patients can't control how or where their weight loss, if they were to lose weight, manifests. Laurel asked about the remaining skin after weight loss. I really appreciated the question about inevitable weight cycling that will happen, and any risks that are there, and whether or not it is ethical to tell patients to get smaller when, as we know, there are no proven long-term weight loss methods or strategies. I will jump in first and say that I have seen a lot of the outcomes of this weight loss to gain access to surgery, and it has like come to me in a lot of distress. Like, I have done all this work, you know, either gotten work done, be it, you know, liposuction or other things in body contouring. I've seen both, that people are just devastated to weight restore. And yeah, it's devastating and heartbreaking to be the person to say, like, I just, you know, this is the science. This is what, you know, we expect to happen when people lose weight quickly and engage in dieting.
Yeah, I think it's such a trap. And that like, again, like totally traps patients. Like, if you do this thing, you'll get what you want, and then the body does what it does to survive. And then something radically shifts and it's not good anymore. Or like, they don't feel good anymore. The way weight loss gets sold to us generally.
Totally
clinically,
appreciated.
it's a mess.
Yeah. Yeah. I appreciated Laurel talking about like we can't control, even if there is weight loss, like where that's going to be.
When you're on gender affirming hormones, sometimes you can gain weight from that. Like my body fat redistributed very differently. Like now I just have all my fat goes to my stomach, you know, and it used to be going other places. So like there could be things that you're taking for your gender affirming care purposes that are also making you gain weight. So it's like, what do I do? Like I'm also on minoxidil that also can cause you to gain weight. So it's just like hard when it's just seen as something that's really easy when it can impact like other parts of your gender affirming care.
Laurel also brought up the insurance piece and doctors perhaps being financially penalized for having a longer surgery time for folks for whom it just takes longer. I really appreciated the questioning of, you know, if it's an insurance issue, then they're just going to pass that cost on to fat folks. As insurance already can be higher, life insurance can already be denied, you know, for fatter people. That, yeah, it's just another way to pass that along as a fat tax.
Yeah, that was exactly what I was thinking. A fat tax. If the cost of that goes up and there's a copay of like 20%, which is like what I've heard on average the most.
Laurel asks how we address the reality of longer surgery without exploiting patients or practitioners. I mean, I want to find the answer to that, but do either of you have ideas or thoughts?
The parallel there with mental health is that like if there's something that comes up in a session deems like need to address now, the rest of my day goes out the window, you know?
Yeah.
And I think that has always been like a reality of the job that I haven't even thought about what it would be like to get reimbursed. Because I also take insurance in my private practice. And I checked. I was just like, do I get reimbursed if I have one of these longer sessions that I have to have for patient safety or client safety? And no, that's not how it works. You know, when I saw that, I was like, oh, it makes sense because that's just like the way it goes, you know? And so I don't have like a solution to that question. I don't know. I just don't think the answer to getting towards liberation is like engaging with systems like insurance, you know? And like, I know that we have to because the United States refuses to give us quality healthcare without engaging in capitalist insurance processes. But I'm like, we're always going to get stuck if we keep trying to like fix a thing that's already fucked.
Yeah.
The majority of my job is dealing with insurance. And what I try to explain to patients is like, at the end of the day, insurance is going to try their best to not pay for anything or pay for the least amount that they have to. So trying to make this like an insurance company's problem is, I don't think, going to be the right solution to this because they're like the most capitalistic institutions, you know, they're not, definitely not. So that is a challenging question because they'll try their hardest to ask for more clinicals to see why this is medically necessary and do their best to deny things or say things are cosmetic and not gender affirming. So that is a great question. And honestly, it's going to have to require, I think, radical activism to change.
Yeah, right? We're back where we started. So that's a great point. I hadn't thought about it in my own private practice. I charge an amount per person with the assumption that I will need to coordinate care like across the board. So if somebody needs more coordination of care, I'm not charging them more. You know, I have factored that in, you know, like averaged or leveled across the board. So I charge everyone the same so that I do have time to, you know, coordinate care for those who need it done. Thank you for bringing that one up. I will say that I'm open to talking with any surgeon ever to find these solutions. And I think it was actually even Blair who brought it up. They were talking about there are clinics who just do this, who don't have BMI limits. Like when we were in Denver, there were people who were just saying like, yeah, we don't have them. And that was it. And for fat folks here, like it's individuals like trying to, you know, do and give surgery for fatter people rather than having like a tried and true, like this is how we do these things, the experimentation aspect of all of this, and how it was also giving like gynecological experimentation on Black enslaved folks. And I don't know. I thought it was an interesting connection there.
I'm just realizing how many things I like had were like passing thoughts and I didn't write down, because that was another thing where like the question was like, okay, if it's a training and expertise issue, well, having been trained in like a medical setting and like knowing how clinical training goes, like you're training on people, like it's a person's body, you know, and how do we respect a person's body and their bodily integrity while training? Like I don't think the medical system has a model that's good for that.
Yeah.
Honestly.
I am really grateful that Blair was able to do this conversation. I'm surprised. I, of course, would love to have more with other surgeons. So I will be and will remain grateful that they were able and willing to come on and talk about this.
Totally.
So I'll leave my thoughts there. Any last words from either of you today?
It's really important as clinicians, I think, to be kind and have good bedside manner, but to remember that like kindness and bedside manner doesn't equal doing the work better or in a way that's like working towards liberation. But kindness does go a longer way than doing it the way that we were taught.
Than being an asshole. Yes.
Yeah.
I just want to say my background is heavily feminist studies, so I tend to be really critical in people of power. So I hope that, you know, you understand that this is just me trying to be critical and it's not an attack. And yeah, I'm really committed to seeing like who's missing in these conversations, and I try to be critical in people in power. So again, that's where my mind goes, and that's what I usually think about. And I appreciate, you know, that there's surgeons who are willing to engage in these conversations, but I would just, again, urge folks who are engaging in these conversations to really reframe their positions of power that they have and really try to approach subjects like these in like a trauma-informed lens, because, you know, you're working with folks who have various forms of medical trauma.
I will also express deep gratitude to the two of you. I so appreciate you coming on, for being in relationship, both collegial and personal relationship with me.
Yeah, thank you so much, Jessica. I like feel very honored to be your friend and work with you and like get to work with someone who has like a lot of deeply held shared values. So
thanks.
It's an honor.
Retweet. I'm very glad I went to the US PATH conference and that we could become pals, because I probably would not have been able to talk to you as much if I didn't go to that conference.
Definitely not.
I don't even go to work on the days that you come in. So
yeah, I appreciate you and your time. Thanks again to Isaac and Zoe for coming on the show and sharing so much of their own experiences with all of you. I'd love to continue this conversation. If you all have suggestions for how to keep the conversation going, you can email it to makingitawkwardpod@gmail.com. And next week, I'm bringing Allison Pill back to the show to start a short series of episodes about writing and publishing a book, particularly a book about bodies. A year ago, I published It's Always Been Ours, Rewriting the Story of Black Women's Bodies. And because of the wild choices my publisher made in marketing my book, Allison became more involved than she or I ever imagined, and it got very awkward. Next week's episode includes Allison's dramatic reading of the letter my copy editor sent me that included descriptions of her own mammy and racist doll. And wildly, that's not even the most awkward thing to have happened with Allison on this journey. In the next few weeks, you'll hear from people like Chrissy King, author of the Body Liberation Project, and Dr. Chucks, who recently published Eating Disorders Don't Discriminate. Now, if you liked this episode, you can leave a rating or review it. You can leave a comment on YouTube, and you can also subscribe to the podcast Patreon, which is linked in the comments. Until next time, make it awkward. This has been Making It Awkward. I'm Jessica Wilson. You can watch this episode on YouTube and Spotify, It's a production of The Body Politic and is supported by Patreon members like you and the legacy of Sacramento Outboard Services. All of the social media clips you see are done by Jen Jacobs, who also edits and mixes the show. Before we go, a reminder that the Suicide and Crisis Lifeline is available 24 hours a day by phoning 988.